Hello, everyone. Hi, my name is Pradnya. For the ones who do not know me, I've been with MedExam for the longest time. My association with them goes back to the time uh, since I was a student. And hi, Rahila. So good to see you back. So good to see you as well. How are you doing? I hope you're doing well. So, as I was saying, my association with MedExam goes way back. I had to take a little bit of a break, but I'm so happy to be back. And I think with one of my favorite things to do, um, there's been this whole trend of talks coming in picture now. Um, and the whole trend of MRCOG Part 2 now is moving towards the whole MRCOG Part 2 now is moving towards talk. And I remember for the time when I was preparing, by the time we finish our NICE guidelines and G2G guidelines in our books, and by the time we start doing the talks, it's very late. So we had an idea that we would do more of these talks and we would summarize it for you so that it is easy for you to go through them. Probably just go through them in a session and then do the CPD questions and you're good to go. So that was the whole intention for doing Tog Talks, and we are going to do more and more of them. So, and we'll keep you guys updated about it. So today we are going to talk about quantification of blood loss and obstetric hemorrhage, its implication on intervention and transfusion. Well, I chose to talk about this talk for two specific reasons. One, that it is from one of the most recent talk articles. It's so clinically significant that I'm sure it's going to be in the exam. And the second is it's also not just a very theoretical topic, it's clinically very relevant. And even if you're not preparing for your exams, you will have something to take back home. Right. So before I begin, I just want to tell you any point during the talk or during the session, if you feel like I'm not being clear, if you feel like if you have any doubts, any questions at all, please let me know. I can stop. We can talk more about it. We can discuss and we'll move forward only when you're clear about it. And yeah, so on that note, without any further ado, let's begin. So what we are basically going to take back from the session is to understand the physiological changes in pregnancy, how it affects postpartum hemorrhage, and how it affects estimation. There are various methods of quantification of blood loss, which is done in a different way all over the world. And there's pros and cons of each. Certain things are suitable and certain things are feasible in a certain place and certain other things are feasible in other places. So we'll talk in more detail about how it's done and what's the best way forward. We'll also learn about different indicators for severity of blood loss. We'll talk about them in detail and we'll try to see how we can take it back to our practice. We'll learn something about point of care tests, which are new and coming up and are very helpful as well. We'll talk a little bit more about machine learning and what's the best way moving forward in terms of how to manage such conditions. All right. So what is PPH? I'm sure you all know what postpartum hemorrhage is. You all have been talking about it. We've been discussing about it since our undergraduation days. We've discussed it in so much detail and to the point that now it's very confusing because there's so many numbers and there's so much of talk around it. But just to make it simple, any blood loss which is more than 500 milliliters within the first 24 hours would be defined as primary postpartum hemorrhage. Right. So RCOG then decided to divide postpartum hemorrhage into minor and major. So a blood loss of between 500 to 1,000 milliliters was designated as minor postpartum hemorrhage, and a blood loss of more than 1,000 was said to be major postpartum hemorrhage. Now, this major postpartum hemorrhage was also now divided into moderate and severe. So a blood loss of around 1,000 to 2,000 milliliters would be moderate postpartum hemorrhage, and anything more than 2,000 milliliters would be severe. All right. It's like maths. It's very simple. It's very segregated in a way, minor and major, and then major goes into moderate and severe. But there is something wrong with that. Does anyone know what's wrong with that, or does anyone have a comment on how we could make it better? Or anyone at all? No? All right, I can do that. Well, the whole problem with just dividing it in numbers is that, for example, if we have a girl who just had a baby and she weighs 50 kilograms and she lost 1,500 mils of blood loss, and she had another lady who weighs 100 kilograms and she lost the same amount of blood. Do you think the both would react in the same way? I really don't think so. It's very obvious, and from our clinical knowledge, we can understand that someone who weighs 50 kilograms has lost over 30% of their blood volume, and they would react in a more severe way, and they would need more aggressive management as compared to somebody who's 100 kilograms and has lost the same amount of blood. I hope I'm making myself clear. What I'm trying to say is categorizing postpartum hemorrhage just on the basis of volume of blood loss, this can underestimate the significance of blood loss. Actually, it cannot just underestimate. Sometimes it can overestimate as well. So if you, basically, it is not the best way moving forward. We need to recognize that total blood volume is dependent on weight, and MRCOG recommends that the clinical response to OBS hemorrhage should be based on the percentage of circulating blood volume lost, and not just solely on the volume of blood lost. All right. I hope I'm making myself clear. If there's any doubts, let me know. I'll stop and I'll repeat it. Okay. What I'm trying to say is, in a person, if we have 15% blood volume loss, which could be 750 mils for somebody who weighs 50 kilograms, it could be 1,200 for someone who weighs 80 kilograms and 1,500 for someone who weighs 100 kilograms. So if someone loses 15% of their body, of their blood volume, it would be moderate hemorrhage. If someone loses 30% of blood volume, this would be severe hemorrhage. And if someone loses more than 40% of blood volume, this would be now called life-threatening hemorrhage. Okay, I hope this is clear. All right, moving forward. So there's so much of talk and there's so much of a discussion about PPH, and there's a reason why we are worried about PPH, because it affects approximately 2% of women who give birth worldwide. It amounts to 27% of maternal death in low-income countries. The 2020 MRCOG report reported that 14 maternal deaths caused by hemorrhage, and in these 79% of cases, improvement in care may have made a significant difference to the outcome. So if probably these 79% of the cases were managed in a different way, the outcome would have been much better. PPH is known to cause significant morbidity, like anemia, coagulopathy, renal failure, pulmonary dysfunction, visceral injury. It can lead to hysterectomy, it can lead to cardiac arrest, it can lead to death. It can not just physically, it can also have a lot of psychological impact as well. It is quite traumatic when you're there and you're bleeding and people are rushing in and people are doing things, birth, which is supposed to be such a special experience for someone can easily be turned into a very traumatic experience, which can lead to postnatal depression. It can lead to post-traumatic stress disorder, and basically have a very negative effect in bonding with the baby, which can lead to long-term psychological trauma, not just for the mom, for the baby as well. In a few cases, it can also affect future fertility if there's been postpartum hemorrhage, which has led to bleeding and hysterectomy, and if there's been Sheehan syndrome, which happens due to hypoperfusion of the pituitary gland. And these are the rare cases which could lead to future fertility being affected as well. And these are the reasons why we need to be very mindful, and we need to be proactive in managing postpartum hemorrhage. Better care and a more systematic and better management of these cases, which are clinical, which are scientific, could lead to more improved outcome. For us to be able to provide this better care to patients, we need to understand what is the physiology of pregnancy and how this affects the bleeding, and what are the factors contributing to postpartum hemorrhage, and what are the factors especially which are delaying the diagnosis, which is preventing us from acting promptly. I hope I'm clear up till this point. Please let me know if there's any doubts, any questions. We can stop and we can talk, and then I'll move forwards. Right. So let's talk about physiological changes in pregnancy and the things that make women more prone to have postpartum hemorrhage. We know that there's increase in plasma and blood volume in pregnancy, which increases by 40 to 50% from the pre-pregnancy state. And this happens so that there's maintaining in circulating blood volume, blood pressure, and uteroplacental perfusion. Now, there's also increase in the cardiac output by up to 45%. And this because there's increase in metabolic requirements in pregnancy, and this further increases in second stage of labor. Now, there's increase in plasma and blood volume, there's increase in cardiac output. Also, as compared to the non-pregnant state, where less than 1% of the cardiac output flows to the uterus, now in the third trimester of pregnancy, 15% of cardiac output flows to the uterus, and the uteroplacental blood flow measures in excess of 700 milliliters per minute, which is quite significant. And you can imagine how fast somebody would lose blood if you wouldn't do something for 5 minutes. Now, all these things lead to very quick blood loss. And this explains why we need to act very quickly, and we need to be on top of things to be able to manage them better. Now, there's been a trend to just wait for symptoms of blood loss, like in a non-pregnant patient. If somebody is losing blood, they would become hypotensive, they would become tachycardic, and that is how we would judge it. But in pregnancy, basically, pregnant women are usually, not always, but usually young and healthy. And because of physiological changes in pregnancy, there is a lot of masking of these symptoms, because women are usually compensating till they deteriorate very suddenly. All right. So because of all these things, just relying on clinical signs alone, I'm not saying do not rely on clinical signs or do not look at clinical signs, but just relying on clinical signs alone to guide the management of PPS, this is going to delay the diagnosis, and this is going to increase morbidity and mortality. So we have to be very, very mindful to take the whole picture into consideration and not just look at the vital signs. Now, sometimes there can be overestimation of blood loss, and some people would say that it's a good thing if you're overestimating, because then you can manage PPH better and things like that. But if you do that, and if you overmanage or give unnecessary drugs which come with its own complications. And if you are unnecessarily transfuse, they come with their own, these things come with their own complications. And we are going to talk about complications associated with blood transfusion in the next few slides. Now we know that underestimation could definitely lead to increased morbidity and mortality, because if you do not intervene, there could be anemia and all the complications that we talked about. Therefore, it is of utmost importance for us to do an accurate and timely estimation of blood loss for a good outcome. Right. So like I was saying, we'll talk about postpartum hemorrhage and blood transfusion. So mostly in women who have severe, moderate to severe postpartum hemorrhage, they will most likely require a blood transfusion. And at that given point of time, it is life-saving, but it also comes with its own risks. There are lots of complications associated with transfusion, like there could be infection, there could be circulatory overload, there could be lung injury, anaphylaxis, transfusion reaction. A more significant complication could be transfusion-associated circulatory overload. And there could be alloimmunization as well, which is thought to occur in 1 to 6% of transfused patients. So all these things, taking all these things into consideration, even though life-saving, we are not going to jump up and give blood transfusion to all patients without them actually needing it. Right, so we've talked about the physiological aspects of things, how pregnant women or women who've had a baby or women who've just delivered are more prone to having a blood loss, and how their body compensates, and we see the vital signs and the signs of hypotension, tachycardia. Usual signs of blood loss would be masked in these women because they're compensating, and we cannot just rely on them. Now, let's go back and let's talk about what we do in a clinical scenario when there is actually a postpartum hemorrhage happening. How in different scenarios we measure the amount of blood loss. So one of the most basic and one of the most easy or common things that's done worldwide is to do a visual estimation of blood loss. Something like this. So you look at the swabs and you look at the blood loss, and you approximately say that it could be 700 mils, 500,000 milliliters, or 2,000, just by your clinical accuracy, or more like a guess. Or sometimes some hospitals have local policies where they have pictorial guides for blood loss estimation, which again is not without error, because these things are very, very subjective. For example, a kidney tray half filled could be 1,500 mils and fully filled could be 350 mils for someone, but somebody could say it's not fully filled. Basically, it's very subjective, isn't it? So we do not need any equipment. It can be done easy. Sometimes training could make it better, but it's highly inaccurate. And this could lead to poor management of postpartum hemorrhage. And different people are going to estimate it differently, and different swabs are going to show you a different type of results. So if you're using a white color swab, which could which could give a better estimate as compared to a green colored one or some other colored one. Basically, it is very variable, it is very subjective, and definitely a very inaccurate way to measure blood loss. All right, so let's avoid doing this. Let's now talk about the gravimetric method. Here, the blood loss is determined by assessing the weight difference before and after use of swabs and drapes. For example, you used 10 swabs in a section. What they would normally do is weigh all the swabs and then subtract the weight of the swabs when they were dry, which would give an estimate. So each gram weight would be equal to 1 milliliter of blood loss. Now, this is quite easy to implement, and it's mostly done, more commonly done. It's easy. It can be done in real time. It can give you quite quick results, and the values are quite close to the actual values as well. But you don't need equipments like the weighing scale. It could be sometimes time consuming as well. But there's a risk of contamination. For example, the swab could soak up amniotic fluid. The swab could soak up, there can be contamination from other fluids as well. And this can lead to a false high estimation. And sometimes there is a risk of underestimation as well. But it gives pretty much good results as compared to just visual estimation. Okay, right. Now let's talk about volumetric technique. Here, basically, we're going to measure blood loss with under-buttock drapes. So, did someone have a question? Okay, all right. So these under-buttock drapes look something like this. So it would collect all the blood that is being lost, and you could see how much the blood loss is on this calibration over here. And this as well gives quite a close result to the amount of blood that is lost. It can be done in real time. It gives us quick results, but again, it can be contaminated. So along with the blood, there can be amniotic fluid, there can be some other fluid, or some of it could be lost, or some of it would not, can just fall on the floor and won't go in the bag, which could also give us wrong values. But again, it is easy to implement. It's said that if you take both together, so gravimetric and volumetric, when they're used in combination, the accuracy of blood loss assessment is improved. Now, these are the usually done things in most of the hospitals. But let's talk about the photometric methods. Give me. All right. So now let's talk about something which is not usually done. Let's talk about the colorimetric estimation of blood loss. So this is a smartphone application, and it is used to photograph swabs and containers. So basically, this app is, you just stand in front of the app. It's going to take a picture of the swab, and this is then going to do a feature extraction technology. I'm not very tech savvy, but and then this is going to assess the hemoglobin mass while filtering out the contaminants. Now, the preoperative hemoglobin is inserted into the app, which is going to provide us an estimated blood loss. Compared with the visual, volumetric, and gravimetric methods of blood loss analysis, this method is more accurate, correlating closely with the photometric method. Now, it is quite a good and quite an accurate method, but obviously it requires all these systems which are not, which we do not have, and which are not easily available, and they're time consuming. And we would always need a preoperative hemoglobin for these. Now, another one that we need to talk about is the photometric one. So here, the total blood loss is collected, hemoglobin is extracted from it and stabilized. So various methods can be used to it. A spectrophotometer is used, and the hemoglobin mass is then calculated. Now, this again is quite accurate, and it is going to give you a blood loss of approximately more or less than 10%. and it is used as the gold standard for hemoglobin calculation. But the problem with this is this also requires equipments, and it's quite time consuming. You cannot get an immediate result, and you cannot, while there's a postpartum hemorrhage happening, you cannot really wait for the hemoglobin result to come back after hours or if not days. So cannot be done in real time, and it requires a pre-op hemoglobin as well. So to summarize, we've talked about the visual methods, gravimetric methods, volumetric methods, photometric, and colorimetric. The visual method is usually quite inaccurate, even though widely performed. Gravimetric and volumetric together could be quite accurate, could be done in real time. It's easy to be done, even though time consuming and has some inaccuracies, but it is our best bet. Moving forwards, we could incorporate the colorimetric one as well, but the photometric one for management of postpartum hemorrhage is not one of the best methods available. Right, so these are the ones that we've talked about. Now let's talk about using early warning scores. So we use modified early obstetric warning scores in assessing patients. We use them for antenatal patients, we use them for postnatal patients, and this was recommended by Center for Maternal and Child Inquiries report that we should be using them. Early warning scores, they show good sensitivity and specificity for predicting maternal morbidity and allowing targeted management of critically ill women. But when it comes to postpartum hemorrhage, how we already talked about, the fact that these women can be compensating very well, and we cannot really just rely on these symptoms for us to pick up postpartum hemorrhage and manage it just based on that. And therefore, they have a lower sensitivity when detecting complications associated with PPH. And therefore, just using early warning scores is going to be unreliable at predicting volume of blood loss. But where the hemorrhage is concealed, for example, an antepartum hemorrhage where it's a different scenario, it might be more important in triggering further investigation. But using early warning scores like MIO score just for managing PPH is not the best method. Now, there were talks about using shock index. Shock index is nothing fancy. It is just heart rate over systolic blood pressure. Now, it is quite a useful tool for assessing morbidity and mortality and the risk of developing shock than just using probably heart rate or blood pressure or just using vital signs alone. It is going to tell us if a woman might develop shock or not, but and there have been a lot of studies that have shown that a shock index of more than 0.9 in women with postpartum hemorrhage will increase the risk of blood transfusion. It will increase the risk of surgical intervention and admission into intensive care unit. Sometimes it may be falsely reassuring, which also affects blood pressure and heart rate. So patients who've had fluid resuscitation or those who've been affected by hypertensive disorders might be falsely giving you values that are reassuring. Therefore, we cannot just use shock index as a tool to predict or use for triggering a PPH management. So we need more studies to assess the impact of shock index on the management of postpartum hemorrhage. So MIO signs, shock index cannot just be used alone for predicting it. Now we need to look into why these obstetric hemorrhages behave differently to other forms of non-obstetric related hemorrhages. So so in pregnancy, these hematological changes, we all know that pregnancy is a prothrombotic stage. So the anticoagulation is, the procoagulation is going up and the anticoagulation is coming down. Because of all these changes, I am not going to go into the physiology of this at the moment, but we know that pregnancy is a pro-coagulative state, but there are different coagulopathies that affect pregnancy as well. Sometimes these women might be on IV fluids for a long time. Sometimes they might have received packed red cells, which can have a dilutional effect on clotting factors, which can decrease this prothrombotic effect. Sometimes there can be local consumption of clotting factors, which can occur at placental site at the time of separation of placenta, or there could be DIC as a result of systemic vascular injury, which can again decrease this prothrombotic effect and increase the risk of bleeding. Following placental expulsion, the hemostatic changes lead to an increase in fibrinolysis, and is further exacerbated in women with severe PPH, which could also make the PPH worse. So I hope I'm making sense. We all know that pregnancy is a prothrombotic state, but certain changes or certain interventions or certain things that happen in pregnancy, either normally or with medical intervention, like giving IV fluids and bloods, may cause different coagulopathies, which prevent this effect or which take this effect away, and there's an increased risk of blood loss happening. So now we are at a point where we are going to look at different indicators for severity of blood loss and if they are going to predict the need for transfusion. So we look at each separately. We look at hemoglobin level. We look at fibrinogen levels. We look at the coagulation, lactate level, and a machine learning algorithm. And we'll see how good each one is in predicting the blood loss and our need for blood transfusion. Okay, I hope I'm clear up till here. If there are any questions, do let me know, or if you have, if you need me to stop or explain anything again, let me know and I'll do that. All right, so let's start with hemoglobin. So hemoglobin levels associated with PPH have been widely studied, but we know from our clinical practice that if there's a PPH happening at a given point of time and we send a full blood count across, first of all, it's going to take us really long for it to come back from the lab, and we cannot really wait for an hour to wait for the result and then manage PPH, which is an acute emergency and which needs to be managed really quickly. Also, a lot of times, these values are not as accurate. So somebody could be bleeding and we send the FBC across and it comes back as 10. But if we measure this 6 hours later, it would have dropped to 6. And we've seen this happening. It is also, again, because of compensation mechanism that women have. So hemoglobin measurement during continued PPH is of a little value because of the time taken for it to process, and it's way too long to allow for any adequate management of postpartum hemorrhage. A better option is to do HemoQ. Now, HemoQ is a point of care test. So this test is available then and there, and it uses a photometer, and it provides a reliable hemoglobin result in 45 seconds from just 10 microliters of blood, which is 0.01 milliliter of blood. Now, this is not going to be as accurate as a full blood count, but it is going to give you a clinical picture. So if you have, say, a blood result of 6, along with hypotension, tachycardia, taking everything into consideration, you could consider doing a blood transfusion. But if your HemoQ comes back as 10 and rest of the observations at that point of time are stable, you could avoid a blood transfusion just not based on the amount of blood loss, if you know what I mean. So RCOG recommends a combination of clinical and hematological assessment to manage blood transfusion. So like I said, take the whole picture into consideration. So probably do a HemoQ, check the observations, make an assessment of the amount of blood loss, and then make a decision for blood transfusion. Right. So the next one that we're going to discuss is fibrinogen. We know that fibrinogen levels increase in pregnancy and higher levels are seen in the third trimester. The normal range is 2 to 4 grams per liter, and the levels could be higher than that in third trimester. During continued PPH, fibrinogen levels of less than 2 grams per liter are highly predictive of progression to severe postpartum hemorrhage. Therefore, our aim is to maintain the levels about 2 grams per liter always. Now, the next thing that we want to look at is coagulation or clotting time. So normally what we measure is we measure prothrombin time and APTT, and this could take up to 60 minutes, which makes this test very unsuitable for use in continuing PPH. Like I said, if there's bleeding going on, you cannot send a blood test across and wait for the results to come back and then manage it. So we again have 2 point-of-care tests, which are going to use viscoelastic assays. So we have thromboelastography, which is TEG, and we have rotational thromboelastometry, which is ROTEM. Now, these are going to measure the different pathways of clotting. There's the extrinsic, intrinsic, and the common pathway. I'm not going to go into the detail of that, but we are going to talk about these point-of-care tests. So like HemoQ, these 2 tests, that is the TEG and the ROTEM, they are going to allow for rapid assessment of coagulation. We are going to use saturated whole blood by measuring clotting factors involved in the extrinsic pathway and fibrin in the formation of a clot. They both work by allowing formation and breakdown of a clot. So it's just going to check in real time how much time it takes for the clot to form and how much time it takes for it to dissolve. And it's going to measure the resistance over time, and it's going to give you a graph. In OBS, now there is evidence of reduction in blood loss and blood transfusion when these TEG and ROTEM were used in combination with agreed algorithms to help guide the management of hypofibrinogenemia and thrombocytopenia at PPH. So how we are going to, so basically this is how ROTEM works. It has this little device where we put the blood in, and it is usually heated and it rotates at a certain force, and it's going to allow clot formation. And this is the detector which is going to see how much time it takes for the clot to form and then for it to dissolve, and then it'll make a graph out of it. Now, so we've got the ROTEM and the TEG. So the FibTem component of ROTEM and the FF value in TEG, this is going to talk about the clotting time due to extrinsic coagulation pathway. And if it is low, it means that this patient needs fibrinogen concentrate or cryoprecipitate. This is quite straightforward. And when using XTEM component of ROTEM and the R-time component of TEG, if it shows, this is basically going to assess the extrinsic coagulation pathway. And if this is prolonged, it just means that the patient is going to benefit from fresh frozen plasma. So these scientific advances are going to help, one, give us quicker results in real time, and two, tell us the kind of management that is needed in that particular patient. Now we've talked about hemoglobin, we've talked about fibrinogen, we've talked about coagulation. Let's come to lactate. Now lactate is well studied. Can
you please show the ROTEM slide?
Yes, of course. Yes, yeah, sure.
Thank you so much. Thank you.
This one?
Yes, thank you. Thank you so much.
You're welcome. All right. Okay. So let's talk about lactate. So lactate is widely used, not just in OBS, in all the specialties. It's seen that in trauma patients, when the lactate levels are more than 4 millimoles, there was increased risk of mortality, and there was a need for massive blood transfusion. Raised lactate levels in PPH have been associated with an increased risk of blood transfusion in women who are hemodynamically stable, with improved predictive performance when combined with shock index. So this has been studied, and it gives us a better outcome. And we all know that on a blood gas analysis, you do get point of care lactate levels as well. So it is rapidly available. You do not have to wait for it for very long. However, for us to still apply it for management of postpartum hemorrhage, we are going to need more larger studies, and it is still not in use just for management of PPH, but there have been studies that say that in association or when used with shock index and in hemodynamically stable patients, it could give a good predictive outcome. Right, so now let's look at the future and the machine learning. So this is the fancy stuff. Basically, algorithms. Algorithms are going to make predictions based on data. For example, ChatGPT. It's just going to predict things, or you ask something and it's just going to answer it for you, isn't it? So the more and more you use it, the better and better it gets. So something similar, machine learning algorithms. These are evolving technologies, and basically you're going to feed data into these technologies, and then it's going to make predictions based on the previous data that was fed into it. So it's been applied to different specialties to assess blood transfusion, and it's been accurately predicting when blood transfusion is needed, how many blood transfusion units would be needed. It's also been used to predict PPH and guide transfusion. It would benefit from earlier transfusion in those that require blood products, as well as reducing unnecessary transfusions. However, we are not still at that stage where we fully understand its implication in OBS. Probably in the future, it would be one of the things we would be using, just putting in the data, and we'll have machine tell us that, oh yeah, if with this data, this person would need a blood transfusion in these many units, but we are not quite there yet, hopefully soon. At the moment, the best way forward is having point of care tests like ROTEM, lactate, hemoglobin, take everything into consideration with the clinical picture and by measuring blood loss accurately, and doing lab tests like full blood count, coagulation screen, urea, electrolytes, having cross-match ready. So even the postpartum management or the postnatal management is done better, or we are on top of things. Also, to add to these things, risk management, picking up the right candidates or picking up the right patients, managing them, doing their risk assessment, and putting them in groups which would require more aggressive management, and cumulative measurement of blood loss would allow for appropriate escalation and team working. So now this is a very interesting pathway for management of blood loss. So the OBS breeding strategy by whales, also known as OBS Cymru, that's how they pronounce it. It's just the recent word, or the more recent word used for whales. So what they did in this project is it was a quality improvement project implemented across Wales, and they encouraged the use of risk assessment, like I was talking about, cumulative measurement of blood loss, team working, use of point of care tests. They developed a checklist incorporating 4 stages. There was a stage 0, 1, 2, and 3. So 0 was doing a formal risk assessment of all the admitted patients for delivery. And actions for those identified as high risk included obtaining IV access, having suitable blood products ready, and active management of 3rd stage of labor. Stage 1 was for patients who lost more than 500 milliliters of blood. So how that was managed by asking for further assistance, requesting involvement of the midwife in charge, and healthcare assistants to help measure the blood loss. Now, this checklist encourages considering the cause of PPH as well as listing the initial steps of management. This was stage 1. In stage 2, if stage 2 was then activated if the blood loss was more than 1,000 milliliter, or if there were actual clinical concerns in the form of abnormal vital signs, for example, a heart rate of more than 30, a respiratory rate of more than 30, a heart rate of more than 120, and a blood pressure of less than 90 or 40, and SATs of 95. So this would prompt further escalation to involve the obstetrician, anesthetist, more frequent observations, additional IV access, bloods for point-of-care tests, laboratory tests, and stage 3, or the final stage, was activated when blood loss was more than 1,500 milliliters, or there was continuing clinical concerns. Here, the patient was then moved to theater. There was activation of massive obs hemorrhage protocol, and there was involvement of consultant obstetrician and consultant anesthetist. So this is just a summary of how it was carried out. So initially, it was seen that there was an increase in the number of cases of PPH because of better diagnosis. And this was felt to be because of better assessment and quantification of blood loss. But when they did it for over 24 months, there was a statistically significant progressive fall in massive PPH in Wales. There was a 22% drop in number of women transfused with red blood cells, and there was a 42% drop in women receiving fresh frozen plasma, which is quite significant. This project has been quite successful and has demonstrated that a care bundle for management of PPH is going to significantly improve outcomes and can be easily adopted by obstetrics unit of all size and care mix. So not just relying on one thing like measuring blood loss or just looking at vital signs or just doing blood tests, taking everything into consideration and doing it systematically by risk assessment and escalating it properly. They saw that the outcome was much, much better. Well, that brings us to the end of our discussion. But before I end it, I just want to conclude it, or the take-home message from this talk would be that there are several methods available for quantifying blood loss. Visual estimation is outdated, it is inaccurate, and it should not be done. Volumetric and gravimetric methods are easier and cost-effective, and even though they're associated with underestimating or overestimating the risk, but it can still be used. Recent technological developments such as the Triton system, the colorimetry, it appears to be accurate to assess blood loss, but these are expensive, may not be available, may not be affordable, and we do need further studies to assess their suitability and application in labor room at this given point of time. So the point of care tests, along with an algorithm, have been shown to guide appropriate and safe use of blood products, reducing the need for unnecessary blood transfusion, at the same time managing postpartum hemorrhage accurately. The OBS Cambry protocol has shown that a combination of point-of-care tests, accurate quantification of blood loss, targeted training, and all of this can reduce massive PPH rates and use of blood products. Studies evaluating the effect of colorimetric analysis in shock index used in combination with protocols may lead to better identification and management of postpartum hemorrhage. Last algorithm for sure. So now this one. Last slide. Is this the one that you were asking for? All right, great. There you go. No. This one? Is this the one that you wanted? All right. Well, the recording would be available on the website. It would be available with our team as well. So if you want, you can get an access and go through the recording again. If you have any questions, if you want anything from the session. Okay. Well, I just want to say thank you so much for joining us on this session. I hope you guys enjoyed it as much as I did. And I'm really thankful that you are here and I had a great time. If you have any questions, let me know. You can always get in touch with the team as well if you have any questions or if you want to reach me in any way. I'm sure the recording will be up and uploaded as well. So you can go through it again. Thank you so much. And I hope this was useful and we'll do more of these. Also, if you have any feedback on how we can do it better or how you would want further sessions, do let the team know and we can facilitate that as well. Okay, thank you so much for being with us. I'll see you guys real soon and we'll definitely do more of these. Thank you. Thank you. Yes, we'll do. We'll do share it in the group. Okay? All right. Take care, everyone. Bye-bye. Thank you, Aisha. Thank you so much for being so helpful. Thank you.